Hello, I'm Salma Khalid, Senior Health Correspondent at the Straits Times. The cost of healthcare has been going up, and people often worry that they may not be able to afford the care they need. In fact, there are many burning questions on healthcare, and I have with me today two people best able to answer them. Deputy Prime Minister Gan Kim Yong, who was Health Minister for 10 years, and Mr. Ong Ye Kung, who's our current Health Minister. Mr. Gan, Mr. Ong, welcome.
Thank you.
Thank you. This feels like MTF again. Huh?
Let's go straight to the first question, okay? In many advanced countries, the government pays for healthcare. In fact, in Canada, there's no such thing as private healthcare. Now, Singapore is a very rich country. So why isn't Singapore paying for the healthcare for its citizens? Mr. Gan?
Well, first, I must say that there's really no such thing as a free healthcare because someone has to pay for the cost of the drugs, of the pharmaceuticals, pay for the facilities, and someone has to pay for the doctors and the nurses, all the healthcare workers. So the question really is, who pays for it? So in other countries, the government may be paying for it, but ultimately, it's the taxpayer who will have to pay for it. So in Singapore's case, we have actually a very comprehensive healthcare payment system, healthcare finance system, what we call S plus 3M, and MediSave, MediFund, MediShield, plus government subsidies. So together with this 3M plus S, we ensure that healthcare will always be affordable. But it is also important to always bear in mind that we must always encourage the appropriate use of healthcare, the right siting of healthcare. This will help to make sure that overall healthcare costs will be moderated. Today, we spend between 4 to 5% of our GDP on healthcare, and this is already a very good achievement compared to other countries, many advanced countries. Although individuals don't pay, the country as a whole pay more than 10% of their GDP on healthcare, and these are paid for by taxpayers indirectly. And despite the fact that we spend only between 4 to 5% of our GDP, the outcome of our healthcare system has been very good, providing good healthcare services, the right appropriate care for our patients, and to help to keep them healthy. And Minister Ong recently introduced Healthier SG, and to help Singaporeans to stay healthy so that you don't need to tap on healthcare services. This is an important move towards moderating the healthcare cost increases. I think if we all come together and support this Healthier SG, I think we can look forward to a healthier Singapore and Singaporeans without spending too much.
Well, what you've said is correct. But, you know, if the government pays for the healthcare, it has greater control. Right? Right now, the private sector is the one that's driving up healthcare costs. And I think Mr. Ong has a big headache with private insurance and private healthcare. If the government were to provide all the healthcare, then it will be able to control the rise and the healthcare wouldn't be spiraling out of control.
Maybe Minister Ong can chip in. I can add on later.
There'll be a lack of choice. I mean,
why will there be a lack of choice? You have three clusters.
Yes, you have three clusters. So within the public sector, there's choice. But there'll be many Singaporeans too who say, I want private for some reason. What DPM Gan, actually he gave all the answer for this interview already. Can go back early. But what he says is absolutely true. There's no such thing as free healthcare. In the end, somebody got to pay for it. In fact, I will go a little bit further to say ultimately the people always pay for it. That is the first fundamental tenet of healthcare. The people always end up paying for all of healthcare. Who else pay for it, right? There's a Chinese saying, 羊毛出在羊身上. It means it's a bit difficult to intuitively understand. The goat's hair always grows on the goat. Doesn't grow anywhere else. So the people always ultimately pay for healthcare. You take, for example, the Canadian system or the UK NHS system, supposedly free at the point of care. They observe it almost like a religion, whether you are Tories or whether you are Labour. And so, but do people really pay for it? Of course, it's all paid for by taxpayers' money. You pay taxes and government use the taxes, fund the NHS, 100%, right? But what's the problem with that, to answer your question? The problem is that when healthcare is free and it's all paid for already by my taxes, people have no discipline. They demand just boom. So today, to get a simple X-ray in NHS, the wait is, I think, 9 months to 1 year. The last I checked, there's 7 million people on the waiting list. The NHS is crumbling under its demand. And then you have a different system to say, then how about don't fund it fully by taxes? Fund it by insurance. Everyone buy your own insurance, which is the starting point of the US system. Very insurance-based, whether provided by corporate or individuals and patients, they buy their own insurance. So that way, you don't have a long queue. You don't have a long queue. And therefore, if you are insured, if you are sick, you go to a private hospital, you can get care almost immediately. However, not everyone can afford insurance. Yeah. So therefore, you look at the two contrasting systems, the NHS from the UK and the US. Starting point very different. The UK started very affordable because it's free, but not very accessible because waiting time is long. In the US, you have the opposite. Very accessible because once you have insurance, you can access private healthcare, but not very affordable. Not everyone can afford insurance. What happened to the two systems now? In the UK, if you have UK friends, you ask them, how do you get prompt care? They say, I buy private insurance, which is available in the UK now. So in the end, you still end up, taxpayers fund the NHS, but you also have insurance. And if you go to the US now, many of the hospitals, and I just visited Johns Hopkins recently, last year, not Johns Hopkins, sorry, Duke University, they say that actually now 40% of their patients come in through Medicare and Medicaid, which is funded and subsidized by government through taxpayers' money, right? So no matter what's your starting point, in the end, you converge to have a mix of both taxpayers-funded healthcare as well as insurance. But that is our starting point. We started off not wanting to experiment either extreme. We went straight to the middle, S+3M. Subsidy together with MediShield Life. MediShield then became MediShield Life under DPM Gun's watch. And then we have MediSave, and then one more layer of safety net, which is the MediFund. So I think, which leads me to the second fundamental tenet of healthcare. How you pay determines how much you pay, right? If you go any extreme, you end up paying much more than necessary. But you have a judicious mix of S+3M, I think we make the system as lean and as efficient as possible. So two tenets. Number one, the goat's hair always grow on the goat. Yeah. Ultimately, the people always pay. Number two, how much you pay is determined by how you pay.
Ministers, can I ask, why is healthcare so expensive? Cost goes up every year faster than inflation. Can the government do more to control the spiraling healthcare costs?
This is for, I think for
well, I can start first, and then Minister Ong can chip in.
Well, it went up during your tenure, then it's going up during his tenure, so I think both of you can answer that question.
First, I think there's always this underlying inflation, which a big component of which is wage costs, because healthcare is very manpower intensive. You need doctors, nurses, healthcare professionals, and a lot of supporting staff as well to take care of patients. And therefore, as wages go up, inflation go up, cost of healthcare will go up. But healthcare cost goes up faster than inflation, as you pointed out, for several other reasons, one of which is also aging. As you know, all of us are growing older, and as we grow older, we consume a lot more healthcare. So individually, our healthcare cost also goes up by the year. And collectively, Singapore as a whole, we are an aging country, and as Mr. Ong put it, we are going into a super aged society. And as we age as a country, there will be more older people consuming more healthcare. The healthcare cost expenditure will go up over time. There's also investments in new capability, new technology, new treatment, which is very effective. But at the same time, cost of this new treatment is also higher. And therefore, there's also this technology-driven healthcare cost that goes up over time. So there are several factors that contribute to this higher healthcare cost. And the government has been doing quite a lot in managing and moderating this increase in healthcare costs. For example, we continuously work with our healthcare clusters to see how we can trim costs to operate more efficiently, more cost-effectively, more productively. So this way, we help to minimize unnecessary expenditure. But at the same time, we also help to right-side our patients to make sure that they are given the appropriate care and not excessive care. This way, we also minimize expenditure on healthcare costs. But ultimately, what is most important is really to keep Singaporeans healthy so that you spend less and consume less of healthcare services. And this way, overall, then we can enjoy savings from healthcare costs. So I think these are the various efforts the government has put in to ensure that healthcare costs increases are moderated. But at the same time, we also make sure that the healthcare cost is always affordable for our population, particularly for the middle lower income, through our subsidy system structure, through our financing schemes. This is one way to help to make sure that they'll always be affordable.
Mr. Ong, your Healthier SG, I think, is this preventive care. How big an impact do you think it'll have, and how long before we actually feel that impact?
I think you have a very powerful long-term impact, but it will be long-term. We have to be patient, do the right things now, so that health is built up over time, and the demand for healthcare is moderated. I just add a couple of points. The cost of healthcare is going up. The cost of delivering healthcare is going up. Manpower is 50% of the cost of healthcare, and manpower cost is going up quite quickly, especially after COVID-19. So you ask, why is it outstripping general inflation? I think that's a key reason. Manpower costs going up very fast. During COVID, I think many countries, not just us, but all around the region and the world, realized that they need more manpower. Yeah, so this is a frantic hiring spree. We lost 17% of our 14%. We lost 14% of our foreign manpower in that 2 years during COVID. Yeah, poached by other countries. Yeah, and of course they poach with higher salaries. So therefore, I think all around the world, because of this strong demand for healthcare manpower cost is going up, and it's driving up healthcare costs. DPM Gan also mentioned technology. There's something peculiar about healthcare industry. In all other industry, whether you buy your handphone, buy your TV, productivity and innovation means you get a better TV, cheaper cost. You get a better handphone, same or cheaper cost. Cars, EVs, you're getting a better EV now at a cheaper cost. Healthcare is probably the only industry I can think of. You get better healthcare at much higher cost. Much higher cost.
Is that because Singapore is charged a lot more than our neighbouring countries?
No, I think it's a global phenomenon. It's the peculiar nature of the healthcare industry. Because it has to do with our health, the well-being of our loved ones. People don't stinge on such things. Where you shop for handphones and say, let's find the one with the best specs but cheapest price. You don't shop like that for healthcare. You just always say, do whatever you can to make me healthy again. Do whatever you can for our loved ones. And technology is available. New drugs are available. Doctors will prescribe to say, let's try this drug, but it costs a lot more, and people will try. That's another reason. I just want to touch on one more reason that DPM Gan may not have mentioned. It's actually insurance has an impact. I mentioned earlier how you pay also determines how much you pay. And insurance is one such factor. Because if we are over-insured down to the last dollar as charged, no constraint, then someone else is paying for the bill. A dynamic will happen. Human nature is human, nobody's fault. It's just human nature between the doctor and the patient. Third party is paying for the bill, which is the insurer or the government. Yeah, and therefore between us, the new dynamic arises, and there is always a tendency for over-servicing and unnecessary treatment. That pushes up costs. So that, I think, is the factor that's very hard to tackle and which worries us a lot.
To follow up on that, Mr. Ong, you mentioned the buffet syndrome, you talk about over-servicing, etc. The public sector actually accounts for more than 80% of hospitalized cases.
About that.
Given that, can't they stop the buffet syndrome? Because they're the public sector, they only give the care that is necessary. And if the bulk of the care comes from the public sector, why is the buffet syndrome such a major factor in our healthcare costs?
It's not a huge factor in the public sector, I would say, because in the public sector, especially subsidized sector, you co-pay, you use your MediSave, and we have the certain clinical control and discipline to prevent excessive, unnecessary treatment and excessive servicing. But I think a buffet syndrome do happen a lot more in the private sector. In particular, if you have a rider, right? Many people actually don't know this, that in S+3M, how it works is that when you get a hospital bill, the first layer of help is subsidy. That's usually the biggest chunk. After that, you got MediShield Life, that everyone is included, so long as you're Singaporean, it pays for the next chunk. And then if you chose for unsubsidized or you go to private care, then what you have is your integrated shield plan, which is a private plan that you buy from the market. And that covers the next level. And then whatever's remaining is called co-payment. And you can also buy what we call an IP rider that also cover the last bit, the residual cost. The IP rider, I'm particularly concerned because when you have a rider and you have many layers from subsidy to IP rider, you practically pay nothing, very little. And that's when the buffet syndrome starts. And that only happens in the private sector where IP rider kicks in. So when we look at our data, someone with an IP rider versus someone who is not is 40% more likely to claim than someone without an IP rider.
40%?
40% more. So it's 1.4 times. The claiming rate of someone with an IP rider is 1.4 times that of someone without an IP rider. And the size of the bill of someone with an IP rider is 1.4 times that of someone without an IP rider. So it's 1.4 times 1.4. So essentially, if you have an IP rider, chances are your healthcare bill is 2 times.
Wait. Let me get that straight. So if I have an IP, one person, and the other person has an IP and a rider, person 2 will likely claim 1.4 times more than person A.
And 1.4
and the
times,
bill is 1.4 times higher.
Yes. Person 2 is 1.4 times more likely to claim. And when they claim, it's 1.4 times bigger than one without an IP rider. So you do your math, 1.4 times 1.4 is about 2 times. Yeah.
Wow, that's a lot.
That's a lot. So
And about half our population have riders today.
More than half, I think. Yeah.
Yeah.
Many
roughly.
people buy riders, I think, for good reasons, and I can understand that, which is to give themselves peace of mind. Yeah. And actually, half the time they don't use the rider. They go to subsidized government care, but they just want that peace of mind in case I need private care, in case I need Class A ward, and my rider kicks in.
Actually, I want to then throw the question at Mr. Gan, because in 2018, he actually stepped in to do something about riders. Before 2018, there were riders that paid the first dollar. In other words, if I have an IP and a rider, chances are I don't have to pay anything for any of the healthcare that I consumed. In 2018, you stepped in and mandated that all riders had to have a co-payment of 5%, but then you kept it at $3,000 a year. That was 5 years ago, and in spite of that, healthcare costs is still going up. So were you too light-handed? Was too little done at that time? Should more have, should you have put in more safeguards against the use of riders?
I think we considered it very carefully at that point in time. It is, as you said, at that point in time, the rider covers the first dollar. That means healthcare is practically free and paid for by insurance. But again, as we stress, healthcare is never free. You eventually pay through the premiums. And premiums will continue to rise and healthcare costs will continue to rise. And therefore, we introduced this non-zero co-payment concept to ensure that there is always a minimum co-payment that patients will have to pay. And that helps to moderate the cost increases in healthcare as well as the insurance premiums. We introduced that concept in 2018. We decided that at the same time when we introduced this mandatory co-payment scheme, we will also want to continue to give patients the assurance that it will always be affordable. Therefore, we decided to have a cap of 3,000. But this threshold or this level, this benchmark, will have to continue to be adjusted from time to time. As healthcare costs go up, it may have to increase over time to keep pace with the overall healthcare bills. But I want to stress and I want to commend Minister Ong for introducing Healthier SG. This, as you mentioned earlier, is a very important step towards managing healthcare costs for the whole of Singapore. And it will take quite a long time to do. And it's not just a Healthier SG program itself. You need to restructure the entire payment system, healthcare financing system, to be aligned with promoting this Healthier SG concept. We need to reward people for staying healthy. In the past, we have always said that health is your best reward. But sometimes, because health only kicks in, or bad health only kicks in when you are older. So when you are younger, you tend to ignore it. And therefore, I think Healthier SG's idea is to have a whole of Singapore approach, whole of nation approach towards healthier lifestyle, starting from young, so that you have a healthier lifestyle throughout your life. And when you get older, you have less dependence on healthcare services. I think this concept is a needle-moving initiative, but as you pointed out, it will take many years for us to see the outcome. We have to just keep doing it, keep prodding it, keep pushing it, and keep encouraging people to sign on and to stick to their health plans. And this way, we can look forward to a healthier Singapore and less expenditure on healthcare services.
So humans are like that. They need to see immediate signals.
Yeah, this
so
is
healthy
deferred
365
gratification is very difficult.
So healthy 365 was really useful. That was under DPM Gun's time. So you walk, you take steps, you exercise, you get some vouchers, you get reward points. Many people don't even redeem those rewards.
So that already exists, but Min Gan says that you need to reward people for Healthier SG.
So now we are doing a second pilot project, which is you can generate health points for your Healthy 365 and use that to pay your premiums.
What premiums?
Insurance premiums.
You mean I can pay my MediShield Life premiums with
You
reward?
can, above 40, I believe. Above 40.
Has that started?
We're going to start next year. It's part of our MediShield Life review package that we just announced. So I think that's another step.
No, but Min Ong, right now with the points, I can get supermarket vouchers and all that. So what's the difference? Why should I use that?
Conversion is better.
Meaning?
The conversion of your health points into MediShield Life discount is actually a very good conversion rate. It's like you go around applying for credit cards and see which one have a better conversion rate for your vouchers, you know. So this one is a very good conversion rate.
So you mean that I may get $10 supermarket voucher, but I may get a lot more in MediShield discount, like $15
Perhaps,
or $20
perhaps.
or $30?
I don't know the exact numbers, but it's a good deal.
But definitely will be more than the
deal,
current
yes.
one.
Yes.
And it's starting next year. I look forward to
So
that.
we want to do that.
Are you 40 already?
Almost.
Not yet, next year. We want to do that, but over time, we will generate the data, actuarial data, to see whether people who exercise more indeed are healthier and therefore claim less. And therefore, they do deserve lower premium. But I think we need a period of time to generate that data.
So this is a big challenge because the program, Healthy SG, is a multi-year, even multi-generation program. It's not, it cannot be done within the lifespan or tenure of any particular health minister. So it's a continuing project, and Minister Ong in time will hand over to the next health minister and the next health minister. So I think this is one way that we always think about long term, and with the results will not be shown in our lifetime or in our tenure. It's going to have to be passed on to the next health minister and to continue. So I think Minister Ong's strategy is really to put in place the structure, put in place the institution to ensure its continuity. So I think this is a very important piece of the work that Minister Ong has done to set in place starting this Healthy SG, and hopefully in time to come we'll reap the benefits of a healthier Singapore.
You know, it's nice to look forward to more rewards for being healthy, but how important is the reward system in keeping people healthy? Do you think it will really work?
No, I think it's important because human beings are like that. We change our behavior based on signals that we get, right? Being healthy and avoiding hospitalization and chronic illnesses in your old age is a very good signal, but it's too far.
Okay.
And as human beings, we don't see so far. You know? We are creatures that like instantaneous reward, immediate gratification. So we do need to internalize some of these signals so that people behave and in a certain way that is actually beneficial for them in the long term. It can come in the form of rewards, vouchers, but it can also come in the form of just education, like the labeling, Nutri-Grade labeling. That was part and parcel. That was part of the war against diabetes measures, and that has been very effective. I see young people now buying bubble tea and say, I avoid D. D is bad now. So there's one thing good about our great consciousness amongst our population is that...
I thought D stands for delicious.
Yeah, no. Which is bad for health, right? Detriment to health, though delicious. So they avoid the C's and D's, they go for A and B's, and it has, I think, changed the palette of a nation. I just make some comments on insurance before we leave the topic.
Right, okay.
I think the problem of rider is a serious one. We've taken some measures to require some co-payment, but fundamentally it is an industry problem. IPs and riders, these are commercial products. And I think we've reached a stage where there is quite unhealthy competition. Why has it happened? Is I think the insurers were fighting for market share. This is not a case of lack of competition. It's a case of a lot of competition. So much so that to fight for market share, they offer better and better terms. I cover this, I cover that. I cover to the last dollar if I can. And as a result, when they start getting more patients and improving their market share, they also find that it's not sustainable. Because as I mentioned, 1.4 times 1.4, that's the bill you are saddled with. So what do? They therefore raise the premium. And therefore you find IP premium, rider premium going up. And it's not sustainable. Many people, when they reach their old age, find that my IP premium is so high, it's not worth me maintaining it, and they exit. I give you an example. I know somebody whose mother went to hospital, quite serious illness, and she told me, luckily, my mother bought rider. I said, hang on. Tell me which hospital. She said, Tan Tock Seng. I say, which class what? Class A. Stay in ICU. So no subsidy. Class A, no subsidy. So I say, break down the bill. How big is the total bill? Over 300,000. Very long stay. ICU plus high dependency. So I say, break down what is the financial support. So about 80,000 government subsidy. Sorry. 80,000 MediShield Life. 80, out of 300 over 1,000. Then I asked, do you have IP? They say, yes, we bought IP. I say, that's good, but that's not a rider, that's IP. IP pay how much? So IP claim is about 200,000. So 80K MediShield Life, 200K IP, 280K. Remainder, she say roughly paid by MediSave. I say, how about the IP rider? How much does it pay? She did a calculation, she checked, 29,000. 29,000. So out of 300 over 1,000, riders paid 29,000, only the residue. So I asked, what is the premium that your mother is paying? MediShield Life, $2,000-3,000. IP, $2,000-3,000. Rider, when you are mid to late 70s, I think you are paying close to 10,000. Once you cross 80, easily above 10,000 today. So therefore, you are paying almost $10,000 in your old age for premium, for rider, to claim a residue. In a big bout of illness, claim 29,000, which is worth 2-3 years of premium. So many seniors are beginning to realize that it's not worth it. It's not worth it. So I think riders is not sustainable, and I think it's pricing itself out. And I think more and more people will realize that. I spoke to the insurance industry, I point this out to them. I believe they understand. And I think we need to do a lot more education effort so that everyone, young or old, we can make conscious decision what kind of insurance suits us the most.
Mr. Ong, in that particular example you gave, I agree, the rider doesn't quite make sense because the amount paid, doesn't justify all the very high premiums. But when you introduce the cancer drug list, right, the IP's coverage of cancer treatment in the private sector in A class is now limited. I think maximum is 5 times what MediShield Life pays. But a lot of cancer drugs are very expensive. The riders can pay 18 times what MediShield Life pays, right? And I'm told by private sector oncologists that people without riders, halfway through their treatment, after 4 to 6 months, they've run out of their IP because there's always an annual cap, there is a lifetime cap, and without the rider, they can't carry on. So whether a rider is important or not depends very much on the type of illness, the type of treatment you are getting. If you're on proton beam, for example, that's another one where the riders come in very useful.
It's quite a separate subject. Can I suggest we do this in part 2? You can grill me on this. Yeah.
Right.
Yeah. But I think I don't want to conflate CDL with rider. It's quite separate issue.
Okay, then let's come back to insurance and riders, right? IPs, about 3 million people in Singapore have IPs. 2 in 3 of them also have a rider, because a lot of people really believe that they cannot do without a rider, right? Especially if they go for private healthcare. In the hospital, in public sector hospitals, A class and B2, B1, the prices are more controlled. In the private sector, it's as charged. So will people in the private sector really require that rider,
I think using the example I raised earlier,
which is Tan Tock Seng?
Tan Tock Seng, but you like Tan Tock Seng Class A, the same dynamics can happen. The same calculation applies.
No, I beg to differ, because the private sector Class A prices are generally about less than half.
No, you go to private sector with no subsidy, you'll find the same calculation, which is MediShield Life will kick in, protect you some. If you have an IP, it's very good because that protects you when you go to private hospital. And then there's a residual. Residual is paid by your rider plus your MediSave. Yeah, and if you don't have enough MediSave, you pay by cash. Yes, but rider is still covering your residual. And if you look at the kind of premium you need to pay, rider's premium are very high. So especially if you're senior, you do have to look at, is it worth it? Yeah. So I think insurers also realize this, that over time, rider is not sustainable and is pricing itself out. It's causing its own demise. So I believe the insurers are also thinking about how to come up with better alternatives to riders. They require maybe a bit more discipline, co-payment, but price lower. So this is something the industry will have to think about and respond. Yeah.
Actually, today, by the time you're about 50, 55, the cost of rider is higher than the cost of the IP itself.
Yes, easily.
And the reason the cost of ride premiums is higher is because there are higher claims against
higher
riders.
claims and higher bills. Yeah, higher claims. And so it's a reason, right? Higher claims, more likely to claim, and each claim is a higher bill. Therefore, it's loaded onto the premium of the rider. Yeah.
It's a risk pooling concept. So if your claims are higher, you're more likely to claim, and all this will add into the need for higher premium, because it's paid out from the premium pool that you collect. So I think you just have to bear in mind that as you get older, you're likely to claim more, and as a result, your premiums also will have to go up. So you just have to make your calculation whether it's worth your while, whether you can afford it, and you'll make a decision whether or not you want to continue with your rider at that point in time.
Do you agree with Mr. Ong that riders don't really make sense?
I think what Mr. Ong is saying is that rider has to be restructured, has to be rethought through, rather than a free-for-all rider that cover everything, other than the co-payment that you mentioned. I think there's also need to have some guidelines on how riders can operate. There will be still some need to cover beyond just IP, but then the key question is how can that rider concept, additional concept, be sustainable in the long term and continue to be affordable and do not end up with a buffet syndrome at the end of the day.
In the end, we all want choices. So riders make sense from that point of view.
One reason for the high premium for riders is because they pay for very small bills. $500 bill, $1,000 bill, they start paying.
No, the reason why rider premiums are high is because what we mentioned, 1.4 times 1.4.
Right.
And then therefore the cost is higher. It has to be loaded on premium.
So
it becomes unsustainable.
Can I ask the two of you, do you or your family members have riders personally?
We do. As I say, most of us make things that rider plays a role. We all want choices. We all want peace of mind. But in that pursuit, and if the rider is not designed properly, and I don't think it is now, it creates an unsustainable vicious cycle, right?
But you are advising people that riders may not be necessary, but you
No,
yourself
I'm
have a
advising
rider?
the insurance industry to please look at your rider, because I don't think because you have gotten yourself into this, the industry better think about how to redress the
situation. You also have to bear in
situation.
mind that riders at a young age is quite affordable.
Yes.
Right? And if you really want to cover yourself for the unforeseen circumstances that rarely happens, but it may happen, especially when you're young, I think riders offers a lower cost protection. But you have to bear in mind that as you grow older, when your claims really kick in, the premiums will go up. You just have to mentally understand how riders operate and make your own informed decision.
I think most people are hoping that they're the ones who make the big claims and everybody else's premiums will go up, so it's spread out.
羊毛出在羊身上. Eventually, you have to pay through premiums. If everybody claims, everybody thinks like that, premium will go up for everyone, and everyone will have to pay higher premiums.
You know, we've been talking about IPs and riders and the fact that the private sector tends to push up healthcare costs a lot more than the public sector. It brings up the question of why the government decided long time before either of your tenure to allow MediSave to pay for private insurance, right? If you had left private insurance to cash entirely up to people and then use MediSave maybe just to pay for Medishield Life, then it wouldn't pull up healthcare costs for everyone.
I'm not sure it's the right diagnosis. Yeah, I think in MediSave is another topic, a big topic for many people. What is really MediSave? It's forced saving for your healthcare needs. Yeah, from your salary, from the employer's contribution, and from time to time, government top it up. So there's a nice nest egg, which is your money in your account, top up by employers, yourself, plus government, that you can use for healthcare. So most Singaporeans will look at their MediSave balance and say, can I use most of it? We mentioned earlier that people don't look so long term. Yeah, the fact is that it's only in your old age that you really need to use your MediSave. 50% of our lifetime 50% of our lifetime hospitalization bills are incurred in the last 90 days of our life. Yeah, but we don't look so far into the last 90 days of our life, and we will be.
You never know.
Yeah, you never know.
90 days.
And you don't know when, and so every day you will be wondering how come my MediSave have money and I cannot use it. So I think over time, government has also been thinking about how to allow people to use their MediSave in a good way, that for their current healthcare needs. So I think other than paying for big hospital bills, we use that for outpatient. Limited amount every year. We also allow it to be used for IP premiums.
Outpatient is fine, but when you allow it to pay for IP premiums, because people do not pay for it, it's automatically deducted from MediSave. They don't think about how much they're paying. And that's one reason why, when they reach a certain age, when they then have to pay cash for it, it strikes them as, wow, it's so expensive. But at the older ages, when they need more healthcare, and if they can't afford to pay for their IPs and their riders, and they drop it at that point and move into the public sector, can the public sector cope with such a huge influx?
We actually will have to cater for that. I think if more people decide to come to public health care, this is not a bad thing. And I think our capacity will have to cater for that. Yeah. But I do not think that using MediSave for your IP premium is the cause of increased healthcare costs. Increased healthcare costs are due to much more fundamental reasons we mentioned earlier. Manpower costs, technology, aging that increase the demand, and then I think there's a catalyst there, which is insurance. These are the main driving forces, not things like whether you can use MediSave for your IP premiums. I really don't think so.
You don't think when people drop the IP premiums because it's too expensive?
I'm saying that is not the cost for higher healthcare costs. Yeah, that's not the fundamental reason. Yeah.
Actually, that brings up another question, right? Insurance tends to push up healthcare costs because, as you said earlier, who pays depends on how much is paid. So if I'm not the one paying for it, then insurance is paying for it.
How you pay determines how much you pay.
I'm sorry, how you pay determines how much you pay. So if insurance pays, then the amount that's being paid will be higher.
Yes. There's a certain buffet syndrome, if we simplify.
Did Singapore make a mistake when we went the route of insurance?
No. I mentioned earlier, every country starts with either extreme. Whether you go totally taxpayers or totally insurance, which is the case of UK and the US. Either way, the people still pay. Either you pay taxes to fund government subsidy, or you pay premiums for insurance to claim, right? In the end, everyone still converges to the middle, which is a mix of subsidy plus insurance plus a bit of co-payment, which is the best way to keep healthcare costs as containable as possible.
So you are saying our system, which has both the S plus 3Ms, which is the government paying, and the insurance model, is actually the best because it's a little bit of
insurance is part of S plus 3M. Insurance is part of S plus 3M because one of the M is Medishield Life, which is a huge part of our financial support schemes.
See, the role of insurance in this case is very important because it is a concept of risk pooling. Hopefully not everybody has catastrophic illnesses, and therefore generally your MediSave and all your basic healthcare financing will be enough. But those who have a very severe illness, unfortunately, very few but very high bills, and those are actually very useful to have insurance as part of the financing scheme. This way we pool all the resources together. Those who are not so sick, then their premiums that they pay can be used to help those who are critically ill, and therefore they have a lot more healthcare expenses. That's a concept of risk pooling. And therefore, insurance has a role to play. So MediShield Life has been designed very carefully to avoid over expenditure, to avoid excessive treatment. So there are very strict guidelines on how MediShield Life can be claimed. Even for IP, although we have a lighter touch on IP because it's private insurance, we do have rules and regulations on how much MediSave can be used for IP, and even IP has a specific prescribed boundaries. You say, for example, you can have zero co-payment and this and that. And therefore, there are safeguards in IP to ensure that, to minimize the excessive use of insurance. But again, as I said, as the landscape evolves, all these schemes have to be continuously tweaked. And even for MediShield Life, we do regular reviews to see how we need to, whether we need to expand the scope, we need to adjust the co-payment, we need to adjust the coverage of the various illnesses it covers or the treatment that it covers. So I think it has to evolve over time. But every time when we do a review, we always bear in mind that on one hand, we want to ensure a good healthcare outcome, but on the other hand, we want to make sure that we do not spend excessively and to moderate the healthcare cost increase. And at the same time, to keep healthcare insurance premiums affordable. So I think these are the various factors that the review committee council will always look at when they look at the review of insurance, particularly MediShield Life.
Actually, both the ministers, both of you mentioned the need to relook the way riders covers healthcare today. I think Mr. Ong also appealed to insurers recently to be more responsible, because you say that they risk a race down to the bottom. So far, nothing has been done. Do you think the government can and should step in to maybe put in rules and regulations for how riders can cover healthcare?
Let's give the industry a chance.
How long are you willing to give them?
Well, by the time this video comes out, I hope they start to do something about it, because they know it's not sustainable. You see, today, nobody's happy with the situation. Insurers, for their health portfolio, either they are making losses or just breaking even with, if one or two may have a slight profit. With doctors, they are complaining a lot to say that nowadays it's so hard to claim. They put us jump through hoops and all that. It's becoming difficult because it's not sustainable. There are signs of being unsustainable. Patients are finding premium going up. Yeah. Government is extremely worried, as you can see. So nobody's happy about the situation. So I think this started as commercial scheme. I more than appeal to the insurance industry. It's a very strong appeal. So I really hope they are looking at it.
Mr. Ong, could I ask you, if you were one of the 7 insurers providing IPs and riders, right, and you're facing this problem, riders being a problem, how would you
Well, I'm not an
change it?
actuarist. I think they will have to really put together their expertise and see how to put in a bit more discipline with a better deal where premiums are not so high. And maybe people will be persuaded and educate. And I think a big part of it is to educate what I mentioned earlier, the kind of examples, if you're old, if you're young, what is your premium versus how much you claim. People need to understand. The great majority of people, actually, we don't understand how does S+3M work, where does subsidy come in, what is IP, what is rider. People don't even know what that is. They just, like my friend, who just said, luckily I got rider, so my mother is protected. Yeah. Little does she know, actually it was MediShield Life and IP. And maybe subsidy, that gave her mother the best safety net.
Actually, I think a lot of insurers really want to do something about controlling riders, but they're afraid of losing market share.
Yes.
And they cannot get together to discuss it because that's anti-competition.
That's true.
So, they're caught in the catch-22.
I will have to talk to the MTI minister about this.
We are always prepared to be flexible when it comes to a national interest, and where there is public interest involved. We are prepared to work with the industry to see how we can all work together to achieve a better outcome for everyone.
But so the MTI is willing to let the MOH...
I would say it is a joke. I would say it is not really a matter of collusion. It is the industry is going a certain way. The players actually rationally should come to a certain conclusion and take certain actions. And I think we are at that stage.
Right. Thank you very much, Mr. Gan, Mr. Ong, for your very frank answers to some of these difficult questions that we all have on healthcare. I hope going forward, that healthcare costs will not go up as fast as it had in the past. Thank you.
I hope
Thank
so
you.
too.